So thank you for inviting me. And so, yeah, last time I was here, Gay Carlson did this. So I'm going to go over a little bit of diagnostic stuff, and then we'll talk about some of the changes that have happened. There's not that many changes in some of the therapeutics, although there are some. I don't have any industry sponsorships. I do research, and so we've got NARCET grants and NIH grants. And I was involved in writing the practice parameter for kids and adolescents with bipolar disorder. Folks may remember I did the one on schizophrenia as well. The one on schizophrenia was not really controversial. It was sort of easy and straightforward. This one almost killed me. And I think this one actually got me kicked off the committee, literally, because it was and it is a controversial area. And you're hearing from someone who's on one side of the controversy. So to be fair, if a different person gave this talk, it might sound a little differently. So, bipolar, and with my research, I care more about diagnoses and getting diagnoses accurate. Once you have that, the treatment sort of follows naturally. And I think this is an area where the diagnosis has been a major challenge. And so historically, right, manic depressive illness was this classic psychiatric disorder, and that people would have these marked mood episodes with either mania or depression. And again, in manic episodes, a classic old-fashioned adult kind of manic episode is this remarkable syndrome that is not mistakable, right? Someone just goes out the deep end and stops sleeping, has all this, often is psychotic, these huge grandiose beliefs. They get themselves in enormous amounts of trouble. That is not a subtle syndrome. And it's certainly not a syndrome to be missed. That illness has the highest suicide rate of all of our illnesses. That 1 out of 5 people, at least historically, have killed themselves with that illness. So it's something that has to be identified, and there are clearly treatments for it. And again, that classic illness typically peaks in age of onset between ages of 15 and 30. That the average age of onset is around 20, although there may actually be a second peak in middle age. I'm still waiting for my manic episode to happen. And this is not an illness that typically ever occur below age 12. This is not a little kid illness. It's also highly heritable. Back in the day, before we sort of increased the frequency a lot, there's clearly these families that look like they have a dominant mutation running through them with this illness.
Kind of classic, right?
That is right. Well, no, 20s. I mean, typically the classic illness forever has been a young person, in their early 20s who all of a sudden, I mean, folks may know this from college, right? You go to college and all of a sudden your roommate has an episode, and that, or in the military also. The military has to deal with this because you're enrolling 18 and 19-year-olds, and all of a sudden people start having their first manic episodes around that age group. So it is a young adult, it's a late teen, young adult illness typically. So if you do adolescents, if you work on an adolescent unit, you'll clearly see this. And when this presents when the classic illness presents in adolescents, they often get psychotic. And historically, they've often been misdiagnosed as having schizophrenia because they're flagrantly psychotic. So, and again, the prevalence in general, it's been estimated to be around 1% of the population, split between bipolar 1 and bipolar 2. And remember, bipolar 2 just means you have hypomanic episodes with depression. That the gender ratio is approximately equal. Oh, and this is where I talk about that there may be this second peak. The issue with prevalence is that the definition you use to define the disorder changes the prevalence rates enormously, because there's all this notion of sort of spectrum cases or atypical presentations, and this really gets into the pediatric literature. Although, to be fair, the adult literature also has lots of discussion and debates about what the actual definition is and how common it is and what spectrum disorders there are. Risk factors for the illness, clearly there's a strong genetic component. The genetics are highly heterogeneous. There has not been any great findings in this area. There's lots of sort of interesting signals, but there has been no set of major definitive genes identified at this point. And I do genetic research, in part because all the databases with bipolar DNA is filled with all sorts of mixtures of phenotypes. And had we just stuck to these narrowly defined pedigrees, we may actually have found something at this point. And hopefully we're actually going to find something soon. We're looking. There's clearly environmental stressors clearly play a role. It's quite common. If you look at people around the time of their first episode, there's some sort of significant stressor going on. There's also this data about child maltreatment, abuse and neglect, and substance abuse is triggering episodes or being responsible for episodes. Some of that starts then suggesting, or at least questioning whether or not that is that a different illness or a different syndrome or a different presentation? And the difference between sort of borderline personality problems or post-traumatic phenomenons and that makes people moody versus bipolar disorder is an ongoing debate. So kids, so again, this has been a controversial area, partly because the definitions, even though we use, the DSM-5 doesn't have a separate pediatric bipolar chapter. It's all supposed to be based on the adult definitions, but the definitions that the literature has used is actually different in significant ways than what has historically been defined. So one, and these are different definitions that people have used, that the Pittsburgh group came up with their bipolar NOS, and so a lot of the studies are about that. These are folks that have what are called subthreshold symptoms. They have kind of irritable or elevated mood that lasts at least 4 hours a day for at least 4 days in your life, right? So for those of you who have taken your kids to Disney World for a week, right, that your kids probably met those criteria. And so that's a pretty broad definition. And then there's the whole rapid cycling. In the adult literature, rapid cycling means that you have 4 full episodes in a year. So complete manic or complete depressive episodes. In the kid literature, it's either ultra-rapid cycling, which you get these really brief manic episodes that last hours to days, or you get ultradian episodes that last minutes to hours. And that when folks present this data, they really talk about kids having 365 manic episodes in a year, things like that. And again, it's not that those kids aren't impaired. I mean, I want to be clear about this. They're working with impaired children, but it's a completely different phenotype. It looks different. And when you read the literature, the definitions of the illness vary all the way from, these ultradian, an episode a day, every day of the year, to chronic baseline functioning. What really is lost in the pediatric literature is these classic cycles that you see in the adult literature. So when folks have looked at, and this is sort of all comers, all the pediatric bipolar literature, what is earlier onset associated with, a longer duration of untreated illness, and frankly probably that's some of a diagnostic issue, because is it bipolar disorder or is it behavior disorders or sort of post-traumatic stress disorder problems is debatable. That they tend to have greater severity of depression and greater comorbidity. And again, these are impaired kids. So as they get older, they're at really high risk for substance abuse problems and conduct and behavior problems. There's a huge overlap between pediatric bipolar disorder, ADHD, and conduct disorder. In fact, all this came out of ADHD clinics is really where this phenomenon came from. It's interesting, there's no increased reported differences between psychosis or mixed episodes, and this is reviewing a pretty large number of studies with over 7,000 participants in them. And again, most of the cases in kids are considered atypical. It's really more this mood and behavior instability. They're highly reactive, lots of agitation, irritability, anger outbursts, explosive outbursts. You hear these descriptions where they're only bipolar disorder at home or they're only bipolar disorder at school, so there can be a lot of situational stuff with it, and again, the classic disorder doesn't look like that. Very high rates of disruptive behavior disorders. The literature has gone all the way down to toddlers. There's studies looking at using olanzapine or risperidone in 2 to 4 year olds, which I don't recommend. And again, this is also heritable in a sense, but probably more in the broader context of impulse control problems. And obviously, impulse control disorders and substance abuse and behavior dysregulation do tend to run together in families. So the controversy is, so when I first started fellowship back in the 1800s, there was no young kids with bipolar disorder. And in fact, one of the first studies I did was sort of looking at misdiagnosis of bipolar disorder in adolescents, because it used to be, it was thought this didn't occur in teens at all. And so if you got grossly manic, you were often psychotic, and so you were called schizophrenic. And there was only follow-up studies that showed, no, this is really more the classic manic depressive illness. And again, for a while, so you never saw a kid with bipolar disorder. We clearly went through this phase where every kid admitted to my program had a diagnosis of bipolar disorder. And it's kind of backed off a little bit since then, partly because of DMDD. That folks are starting to use that more, although I don't know that the researchers in this area have changed their views about this at all yet. And so some people in the pediatric business estimate that the disorder is as frequent in kids as it is in adults, which epidemiologically doesn't make sense because it doesn't go away usually. It's usually a chronic disorder. So if it's 1% of kids, it should be much higher in the adult population. And some people believe it is much higher in the adult population. When you start talking spectrum stuff in adults, it also like 6 to 8% of the population has kind of mood instability and mood reactivity problems. And really, to me, part of the controversy has been it's such a classic adult disorder with very clear treatment guidelines, and the treatment can be life-saving. So if you really have bipolar disorder, you really should be using antipsychotics or mood stabilizers, which also, so if a 6-year-old's got it, that means you should probably do it in them. If a 2-year-old has it, that means you should probably use it in them. And so what you call it really does matter. And, well, here, I'll show you the data. I don't know how you can see that. Anyway, this is, again, in some ways using the kind of data we talked about using here. These are Medicaid data or office visit data, insurance data. This is looking at the change in diagnostic practices over time, and you see this, the darker line upwards is the change in the rate of diagnosis in outpatient practices in pediatrics. The adult population changed a little bit. That's the fainter line. But again, that's right. If that was a stock, you'd be doing pretty well right now, right? There's a huge increase in the rate of the diagnosis. And I'm sure it's just random coincidence. At the same exact time, that's the change in the rate of prescriptions for antipsychotic medications in the United States in kids. There's completely parallel lines. And folks may be aware there's actually been a bunch of lawsuits about this. Several states sued several of the industries to go ahead and get money back because of false marketing claims and specifically over this diagnosis and the overuse of these medicines in kids. Because of all this concern, DSM-5, in a way that doesn't happen very often, they basically created DMDD to tell child psychiatrists to stop diagnosing everyone with bipolar disorder, right? And they kind of tell the researchers to knock it off. Now, they didn't quite say it that strongly, but that's what the message is. That there are all the, and this, of course, I think there may be a separate talk about this, but this is about 3% of the population or so. And the goal was to capture moody, explosive, angry kids in this category rather than the bipolar category. The interesting dilemma with this is, I'm completely in favor of this. The dilemma is you've got all this research from DSM-3R to now, and it's not clear what to do with it because it's not clear what those kids have. And so anytime I sort of read a study or review a study, the first question is, what bipolar disorder is it? Right? Is it the classic one with these well-demarcated episodes? It's really an older person's problem. Is it pediatric, which is these regular, frequent, intense outbursts? At least in the Washington state, for a while, every moody, angry kid was called this. And so, and now you've got sort of the severe mood dysregulation category to put it into. And I think as we move into standards, and this was the really difficult thing in writing the practice parameter, you absolutely need to capture the standards for the classic illness because that's really important to recognize and treat. On their hand, you have to be a little careful about giving people full license to extrapolate those standards to every kid called bipolar disorder because they'll all end up on a bunch of different medicines that have side effects and so on and so on. And I don't have an answer for that, to be honest. I mean, ultimately, we had to sort of decide on warning people about the controversy, educating them about the diagnostic practices, and then still presenting the best recommendations to treat the core disorder, because if someone really has the real disorder, you do need to treat it effectively. So, how do you treat bipolar disorder? This is from the adult literature, and we'll talk about the kid literature separately. That it's basically a medication therapy specific treatment. Clearly psychosocial therapies are important too, but there's no way to treat the classic one without medications at this point. And the medications are sort of phase specific, treating acute manic episodes, treating depressive episodes, and then maintenance therapy that once you get them stable and back in remission to help them preventing future episodes. There are clearly psychosocial therapies that help this, to help people address their mood states, their functioning. Relapse prevention is a huge issue with this illness, that people generally go 5 episodes of mania before they realize that they really do have to take their medicines, and after 5 episodes, many people have really screwed up their life. And again, even in the classic disorder, there's lots of comorbid conditions, with substance abuse in young adults being the biggest problem. There's a huge problem with substance abuse in this population. So, what are the meds that we treat it with in adults? This is, again, adult literature and the kid literature. This is one area where the kid literature does have some significant differences. So to treat acute mania, antipsychotics, lithium, and the anticonvulsants, especially valproate, carbamazepine, oxcarbazepine, all have been shown to be efficacious for treating acute mania. Depression and bipolar disorder is hard to treat. That there's not a lot of great data about how to treat it. And you'll notice antidepressants, except in a combination with olanzapine, are not on this list. That it still remains a question whether or not you should use antidepressants in someone that has full-blown bipolar 1 disorder. And the reason fluoxetine's on there is because they market it together with this olanzapine-fluoxetine combination. It's both, and you'll see it, that someone studied it in kids now as well too. Lorazepam, which will be one of the new additions, I think, that needs to be on the guidelines, has been really pushed hard by the company that makes it, and it now has an FDA indication for bipolar depression. And since not many things do, that sort of stands out that way. Lamotrigine specifically has one for depression. There is some concern that the initial lamotrigine literature was pretty strong for this in adults, and some of the subsequent literature has been sort of less strong. And then there's maintenance treatment. Maintenance treatment is really sort of the key for treating this disorder, that once you get them through the episodes, preventing future episodes. And for all this, lithium is really the gold standard. The lithium's been around for a long time, and when it works, it's sort of miraculous when it works, frankly. But also, there's some evidence for antipsychotics and for using valproate in adults. So that's kind of what the adult literature says. In the kid literature, there's now several FDA-approved agents for treating this, mostly for treating mixed or manic phases, and again, mostly in the atypical antipsychotics. Lithium now has an indication. There was a study that was sponsored by the NIH. I was part of it for a little while, the COLT study. And it had always been sort of FDA approved in kids, but it was grandfathered in. So there's now data to support that approval. And at least on all the websites we can find, it says 12 to 17 years. Sandy was at a meeting last week and heard that the FDA has moved it to 7 years, but she and I just looked and we couldn't find it, so. Yeah, although when you look on the FDA website, we just looked again to make sure, it still says 12, so. But anyway, the word on the street is it may be going down to 7. Most of these, obviously, these are mostly based on industry trials, and so you can see the studies tend to follow a similar design, so that most of them are approved most of the atypicals are approved between the ages of 10 and 17 years. Olanzapine's a little older, and we'll talk about the olanzapine data. You have to take into account the weight gain problem with it. And I highlighted in red, I think, the newer things that have happened, at least that lorazepam has now been shown to be helpful in kids with bipolar depression, quote unquote bipolar depression. And so it's got an FDA approval for 10 to 17 years. And there's one kid study that was industry sponsored that looked at this combo drug of olanzapine and fluoxetine and showed that it helped for bipolar depression as well. And so it got an FDA indication for that. And that's something, as we talk about the guidelines, we didn't really address this the last time, so we'll have to think about how to best to address that. The feds did a big review of all this, a meta-analysis of 19 clinical trials, of which 14 were randomized controlled placebo trials. Most of them, so partly like all of our literature, most of them were short duration of trials, 3 to 8 weeks. The age range was anywhere from 5 to 22 years of age. And in general, the second generation agents are helpful for manic episodes and for mixed manic episodes, however the studies define those. And you do see improvement both in symptom severity and in functioning. They're not all that helpful for depression. They're more helpful, again, for the irritability or the mania or the anger outburst. And again, this is where the literature overlaps with the aggression literature that we just heard about. And that, like everything else in our field, most of these are placebo-controlled. Most of these were designed to get FDA approval, and so we need studies that compare one agent to another agent, but there's not very many of those. So just in going through the different classes, and the last time I think, and I raised it up a little bit, the guidelines were a little less favorable about lithium. For the classic disorder, lithium is clearly a first-line treatment. I mean, lithium is there's only 2 agents in our business that have ever been shown to prevent suicide, lithium and clozapine. And so if someone really has the real disorder, they should get a shot at lithium at some point in their career. And I mentioned before, the COLT study, Bob Findling led this study. So there's now data in pediatrics that shows that it works for both acute mania, that was randomized data, and then there's also an open label maintenance phase that shows that it was helpful for that as well. And then Ann Duffy in Canada has a little different view of pediatric bipolar disorder than we do. As she put all their data together, she really was pretty clear about what, and I agree with her, that it really is helpful for sort of the classic manic depressive illness. It's less helpful than the atypicals for sort of the explosive, aggressive reactivity kind of problem. And so and she came out with a guideline for this, really recommend more for the adolescents with the classic disorder and not for the little kids with old-fashioned American pediatric bipolar disorder. So this is one area that's really quite different. There are all these industry trials trying to show that the anticonvulsants work for pediatric bipolar disorder. These are all randomized controlled trials compared to placebo. They don't work. There's older reports where we sort of compared risperidone to valproate or valproate to risperidone, valproate to lithium. They're smaller kind of open label studies and they report some benefit. But when you actually do these larger trials where you're comparing to placebo, not one of them worked. And I think, to be fair with all this, if you look at the current evidence, it does not support the use of using anticonvulsants as mood stabilizers in kids. I think it's also fair to note this was done by people that diagnosed pediatric bipolar disorder much broader. I mean, this included young kids, kids as young as 3 years of age, and so I think this data probably reflects as much as the aggression guidelines as it does for the real bipolar guidelines. These agents just don't seem to be all that helpful for people with reactive, explosive anger outbursts. And some of them, I mean, the valproate study, they did worse than placebo. It's not like it was close, so. Okay. So pediatric, or just in general, bipolar depression, these are both industry-sponsored trials. The olanzapine-fluoxetine combination was positive, or was helpful in an 8-week randomized controlled trial. Of course, they had problems with weight gain, that they gained 4.5 kilos over 8 weeks. That the olanzapine trial for just mania and mixed mania, it was only a 3-week trial, and the kids over that trial had gained again, about 1 kilo a week. And so at some point, and keep in mind these studies stop at 8 weeks, and so whether or not the weight gain is acceptable after 8 weeks, it's not like it levels off after 8 weeks. And so there are significant concerns about using olanzapine by itself or in combination, and generally it probably should not be used as a first-line agent in kids in general. And then lorazepam. Lorazepam has gotten itself FDA approval for a lot of things now. It's being marketed like crazy. We had the Academy meeting last week and had like neon signs blinking lorazepam as you're walking in the room. So they had a positive 6-week randomized controlled trial that was published. The Orange Journal asked me to write a little commentary about this, and I fussed with them a little. I fussed with them a lot. That part of the issue, when you do these really large, I mean, right, everyone wants large studies, so you've got power to find effects, which makes perfect sense. The issue with that is that you can find small effects that are statistically significant. And so the issue is whether or not it really is clinically that meaningful. And when you look at their data, there's this little decline in depressive scores, which you can say is clinically significant, barely. That didn't really change the functional outcomes at all. And it didn't change the rate of kids that had remission from their depression. And so while it's a positive study, it's not like it's a miracle cure or that it changed the world, at least as far as I was concerned. They disagreed. They wrote a letter back, so we're all getting along fine now. Okay. The issue of antidepressants and bipolar disorder, and this is one that where I think in clinical care and communities is all over the place. Again, with someone with the old-fashioned classic disorder, you probably want to avoid antidepressants. It unstabilizes people's moods, it will cycle them into mania, and really the goal for maintenance treatment and for treating depression is to get them back to the baseline, so you usually use maintenance agents, again, like lithium for doing that. However, of course, there's lots of reactive, angry, irritable kids who are unhappy and miserable, and so that their antidepressants are used all the time in those kids, and whether or not it's helpful or not is, I think, needing to be determined, because there's not a lot of studies of that there's not a lot of studies of antidepressants in pediatric, there's not really any in pediatric bipolar.
But isn't it the case that kids or adults, if they have bipolar, spend more time in depression than they do in mania?
If you have real bipolar, the depressions are horrible. I mean, if you think about like a thermostat illness, so mania, it's turned too high, depression, it's turned too low. So they're psychomotor obtunded, they may sleep 18 hours a day. Some people get outright catatonic with the illness. And again, the suicide risk is enormous. And so it's not that they're not depressed, the issue is how best to treat it. Because the antidepressants, again, by increasing the risk of cycling, they may feel better in a week and they may be manic in 2 weeks is the problem. And partly it's just based on the data. And this is more of adult data. There's just not good data that antidepressants are actually that helpful for them. If you're going to use them in someone with the real disorder, you really make sure that they're nice and stable on their mood stabilizer, their antipsychotic, so that, again, they've got a buffer from cycling, and then you try it there. And I think usually the first goal is to get them stable on their mood stabilizer and their antipsychotic and see if they level out. There's this natural pattern of the illness that, if you look hard, you almost always find. So somewhere around the mania, there's some period of depression either before or after, or both, that they go through. That's one issue. The other issue is if you take someone who's acutely manic and grandiose or just over-energized and you put them on a medicine to stop that, they feel depressed because it's, compared to feeling like you're God, it sucks. And so you have to kind of help them wait through that period of time. And they'll often complain bitterly, not just about their moods, but, you're slowing me down, I'm not creative. And some of that is true. I mean, in fact, that you are doing that. But I think you need to be careful about sort of adding things versus let the medicines work and let the natural course of the disorder work its way out. Does that make sense? Anyway, and with the obviously bipolar 2 or some of the other people that don't have as marked of manic episodes, I think it becomes more reasonable to try these, but again, it's not a database thing. There's not great studies about using the antidepressants in bipolar or bipolar spectrum or pediatric bipolar. They're just not very well studied in this population. Clearly the psychotherapeutic interventions are important. They're also hard, again, to find people that do them. And there have been folks do these specific treatment developments where there's things called child and family focused CBT, working on both the symptoms of the illness and the impact of the illness on sort of stress and functioning in the family. There's family focused treatment. There's this woman that did this at University of Washington, interpersonal and social rhythm therapy. That partly, if you have this illness, it's really important to have sort of more set schedules. This is not an illness that you want to pull all-nighters studying for a test or, and some of it, frankly, this is just good therapy for adolescents in general. Try to keep a regular schedule, try not to date crazy people. I mean, sort of don't use drugs. I mean, the same kind of things you whine at your children about. This sort of puts it into therapy. And then a lot of effort on relapse prevention and really treatment adherence. With the real illness, getting people to take the treatment is a big issue. It's a big issue. And frankly, the ones that get classically manic and euphoric remember the euphoria better than they sort of remember that they felt great and then they met you and you put them on stuff that made them feel like crap, right? That's not very helpful. So, the guidelines, I'm gonna...
All right, folks. So we do thank you very much.